share it. If you go to registerednurse.com, there are APGAR practice questions there that you can practice with. I'm going to put all the recordings on YouTube so that you'll be able to listen to these recordings and go back. I encourage you to go into the Saunders book, into newborn assessment and postpartum assessment under content, and do those questions in study review mode and try to answer the rationales for those questions. All right, so here we go with chapter 24. So really, chapter 24 is talking about the newborn, okay, and some of the things that the newborn might go through when they come into the world. We have to be able to recognize that some of these parents are going to need extra support because they're expecting their newborn to come out healthy and okay and like every other baby. Now, some of them won't expect that because they'll have gone through the testing and they'll understand that their child is at risk for certain things because of the tests that they went through, you know, because the mom was either older or because they've had other children that have had genetical problems. All these things would cause us to look closely at one client versus another. So during this time, we're going to have to provide emotional support to the parents. Okay, if you've never been in this situation, and I'm not sure how many of you are, but I raise a lot of foster kids. I had a foster kid last year that had a child that was born with encephalopathy. How many of you are familiar with that? So basically, the child was born without a top to the brain. And when you pick the baby up, you can see right into the baby's brain. When the babies are born like this, they're not viable. The baby's not going to live past a couple of days. But what happens is sometimes these babies live 7 or 8 days. And the parents will actually get this hope that the baby's going to live and survive, but he's not. The only baby that I know that survived longer than a few days with this is baby Jackson. So if you get a chance, look up baby Jackson, encephalopathy, and watch the video. All right, he had a little bit more advantages than some of the other kids because of who his parents are and because of the fact that they didn't give up. I believe he lived to be about 4 years old. He did eventually die. All right, so our main job during this time is going to be therapeutic communication and support. This is a crisis, okay? We do want the baby, once stable, to be able to spend time with the parents, and we want to promote that bonding even if the baby is not going to survive.
Ms. Loesch?
Yes.
What chapter are you on right now?
Chapter 24. Can you see the slide?
No, it's still on 18.
Okay, so let me just do a new share here. How about now?
All right, I see it. Thank you.
Okay, so we're looking at the attributes of the baby that are positive. Those are the kind of things that we would want to point out for the parents, not the negative stuff. All right, so maybe their cry, you know, anything that's healthy that we could talk about to help decrease the parents' anxiety a little bit. So we have 2 types of disorders, okay? We have acquired and congenital. So acquired disorders may occur at birth or after birth, and they're usually due to problems or conditions that are experienced by mom during her pregnancy or at birth. We may not know what the causes are, but we look at healthy indicators, okay, and that talks about the number of infant deaths that we're trying to decrease. So when we talk about these acquired disorders, we usually don't know the identifiable cause for the disorder. Sometimes it's associated with labor and birth or prolonged rupture of the membranes or fetal distress. or congenital disorders, we usually see some sort of structural, functional, or metabolic abnormality at birth. Most common ones are congenital heart defects, neural tube defects, Down syndrome. These disorders generally involve some sort of problem with inheritance, structural anomalies, commonly referred to as birth defects, chromosome disorders, and inborn errors of metabolism. Most of these congenital disorders have a complex cause. That may involve the genes, the products of the genes, some sort of social or environmental factor, and we might be talking about the way the organs themselves developed. Some of the alterations can be prevented and others cannot be changed. Usually acquired disorders are not passed genetically or caused by some hereditary or developmental factor. They generally occur after birth from some reaction to the environment outside of the body. Examples of acquired disorders would include things like hypoxic, ischemic encephalopathy, respiratory distress syndrome, Meconium aspiration syndrome, persistent pulmonary hypertension of the newborn, intraventricular hemorrhage, necrotizing enterocolitis, or retinopathy of prematurity, hyperbilirubinemia, and some other newborn infections, some sort of trauma at birth. So those would be the main causes of the acquired condition. With the hypoxic ischemic encephalopathy, the baby's lungs are filled with fluid, and we have to get rid of that fluid because the baby now needs air in the lungs. Most babies make that transition within a minute of being born, and they're able to breathe on their own. If the baby is not able to establish that first respiration and clear that fluid out, they're said to have asphyxia. And that would cause an impairment in the gas exchange. Again, that would lead to hypoxia or hypoxemia, and the baby would have more carbon dioxide in the blood, leading the baby to develop hypercapnia and acidosis. All right, so that would put the baby at risk for hypoxic ischemic encephalopathy. For these babies, we would look at things, what sort of things would trigger us to look closer at that. So we're looking at the color, right? We know the color should be at least pink on the body, even if they have the acrocyanosis on the hands and the feet. We look at the work of breathing. You'll see this always abbreviated. They talk about this with kids all the time, and they usually will abbreviate it WOB. All right, how easily are they able to breathe? What's their rate? Are they having any retractions, any grunting, anything like that? What's the heart rate? Remember, if that baby's heart rate goes below a certain number, we're going to start bagging it. What's the temperature and what were their APGAR scores? Of course, we have to resuscitate. All right, again, why the neutral thermal environment? Why the blood glucose levels? Why are we worried about that? You guys notice, we just talked about it a little while ago. If the temperature is not maintained, what's going to happen?
Blood sugar.
Okay, they're going to go into respiratory distress first, right? The body's not going to be able to keep up with the metabolism. They have limited blood glucose supplies because of that immature liver. So it's just going to be a cascade event. Baby will try to use compensatory measures like tachycardia or vasoconstriction to bring the oxygen around to the vital organs. But if we don't intervene, the baby's going to develop hypotension, bradycardia, and eventually go into cardiac arrest. So when we keep the baby within the normal realms, we can help it. Now, for this baby that goes into this type of distress, they actually might put the baby in a hypothermic condition as part of a neuroprotective intervention to support this. All right, so in the NICU, they might use hypothermia to prevent damage, such as reperfusion injuries. And it works to stabilize the brain cells and prevent inflammation. Some infants that have encephalopathy will benefit from the hypothermia, and some will still develop adverse outcomes. So they are working on things to help these children. And that's really for the hypoxic, ischemic encephalopathy. That's what they do the hypothermia for. All right, so if the newborn doesn't respond, then we have to resuscitate. That ventilation will help them. We use a bag mask valve, all right, BMV. And we also will use endotracheal intubation if the respiratory depression continues. We have to make sure the baby's warm, so we want to make sure we've gotten all that fluid off. Make sure they're dry. And that might be all they need to stimulate the breathing. If they don't respond to that, then we may have to resuscitate. For the newborn, resuscitation, always remembered by compression airway breathing, CAB. Resuscitation until the baby has a pulse above 100, a good healthy cry, or good breathing efforts. All right, that tells us that the oxygen supply is now good to the brain. If resuscitation efforts have continued, 10 minutes have gone by, and there's no detectable heart rate, resuscitation will be stopped after 10 minutes. For transient tachypnea, what we'll see is respiratory distress, delayed clearance of that lung fluid, causing that transient pulmonary edema. Edema. Can't talk. Baby gets that mild respiratory distress within a few hours of birth, resolves in 72 hours. Again, the fluid's not clearly removed from the lungs. All right, so they have this excessive pulmonary fluid. Treatment is supportive, low oxygen. All right, they might give IV fluids, gavage feedings, supplemental oxygen, and of course, always keeping that temperature up to par. Following statement, true or false? Neonatal asphyxia commonly resolves within 24 hours after birth.
False.
Good. Neonatal asphyxia requires immediate resuscitation and may lead to hypoxic, ischemic encephalopathy. Transient tachypnea resolves 24 hours after birth. All right, so we have to look at causes of respiratory distress. This will affect the baby's ability to breathe. It's usually caused from lung immaturity, or the babies don't have enough of the alveolar surfactant. The surfactant is what keeps those air sacs or that alveoli open, or it keeps them from collapsing and allows them to inflate easily. If we don't have their surfactant, then the alveoli will collapse at the end of expiration. We use prenatal steroids to accelerate the lung maturity and development of the synthetic surfactant, and that helps improve dramatically the outcome of a baby with respiratory distress syndrome. Babies born between 26 and 31 weeks of age have a much higher risk and may need intensive respiratory care with mechanical ventilation. Lung immaturity and surfactant deficiency contribute to RDS. The immature lung cannot support oxygen or ventilation because the alveolar sacs are not sufficiently developed, and the surface area that they have is not large enough for the gas exchange to occur. The amount of surfactant present is not enough to stop the alveoli from collapsing. Surfactant helps form a coating over the surface of the alveoli, and it reduces the surface tension, and it prevents the sacs from closing at the end or collapsing at the end of expiration. The lack of surfactant results in stiff lungs. So that means if the lungs are stiff, they don't have that ability to be compliant, to expand and contract the way we need them to. And that can cause atelectasis or collapse of the lungs. The little sacs in the lung will become deflated. The work of breathing will be increased. We'll see an increase in the hypoxemia, and acidemia or acidosis may develop. Eventually, that can produce ground glass appearances in the lungs, and that can cause further decrease in the gas exchange. So what we'll see with respiratory distress syndrome is the client will eventually develop hypoxemia, acidemia, and a worsening respiratory distress. So we want to make sure we look for those signs of respiratory distress and other conditions like the transient tachypnea, the group B strep pneumonia. Common risk factors for development of respiratory distress are prematurity. Other things are C-sections, malgender, having a baby previously that developed RDS, asphyxia, cold stress, and moms that have diabetes. Prolonged rupture of the membranes, gestational or chronic maternal hypertension, narcotic addiction, use of steroids prior to birth, all can put the baby at risk. So when we're scoring, you're looking at all these things, okay? The grunting. A lot of times you can hear the grunting without the stethoscope, by the way. The nares, you can definitely see flaring. Anywhere around any rib cages, the xiphoid process, you'll see the retractions. You'll see the skin looks like it sort of tucks up underneath the bone. So you're looking for grunting, shallow breathing, nasal flaring, chest wall retractions, seesaw respirations, which means one side's going one direction, the other side's going another. Generalized cyanosis. Any heart rate above 150 to 180. Fine inspiratory crackles, tachypnea. So tachypnea would be above 60 breaths per minute. Supportive care, okay, these are the things that you're going to do. Again, the ventilation, they might need a CPAP or a PEEP. They may need some sort of surfactant being given. Exogenous just means we're getting it from outside of the body. If they do develop metabolic acidosis or any sort of sepsis, we're going to have to give them antibiotics. We may have to correct the metabolic acidosis with bicarb. Fluids or vasopressors if the blood pressure starts to drop. And then, of course, we got to monitor for hypoglycemia, because if they can't maintain their thermoregulation, and if they're using a lot of energy, they'll use up those glucose supplies. Remember, glucose supplies energy to the body. So we want to cluster care. We can put the baby in a prone or a sideline position to optimize their respiratory status and take advantage of gravity, suctioning to get rid of the secretions, and then support. if they aspirate the meconium. This can cause hypoxic stress or hypoxia. All right, so what would be a risk factor? If you see on the nail, skin, or the umbilical cord that meconium stain, a barrel-shaped chest, prolonged tachypnea, remember that's over 60, increasing respiratory distress, those intercostal retractions, or anything that shows that increased work of breathing. So that would be the retractions, the grunting, the cyanosis. So we see this in both term and post-term infants. It's that baby's first stool. All right, and they've swallowed it or they've aspirated during labor or birth. It's usually mixed with the amniotic fluid. So a lot of times it will happen while the baby's in utero or when they take the first breath. This can cause airway obstruction. It can cause dysfunction of the surfactant, hypoxia, or they can develop inflammation in the pulmonary tissue, pulmonary hypertension, and death from this. The etiology is not well understood in meconium aspiration syndrome, but we do know that it's very harmful to the baby. It alters the amniotic fluid, reducing the fluid's ability to fight bacteria, increasing the baby's risk of perinatal bacterial infections. And the meconium is irritating because of the enzymes that it has from the baby's pancreas. When it gets into the lungs, it blocks the bronchial, causes inflammation. It causes the surfactant to be decreased. It impairs the gas exchange, and then the alveoli will collapse. We may see respiratory distress and then persistent pulmonary hypertension, shunting of the blood from the right to the left, and a patent ductus arteriosus. Remember, the ductus arteriosus is supposed to close after birth. But in these clients, it may not. And because of that, we'll see poor eating, failure to thrive, and breathlessness. So you're looking at the amniotic fluid for this, okay? You see any sort of staining, that green stained amniotic fluid, that suggests that meconium is present and you need to report it immediately. You're also going to look for a yellowish green stain on the umbilical cord, the nails, and the skin. Look for the barrel-shaped chest. Look for the increased anterior posterior chest diameter. Remember, that should be equal, the anterior posterior. Look for the prolonged tachypnea, so past 60 breaths per minute. Baby starts to go into respiratory distress, develop these retractions, the grunting. Also, the lungs may have crackles or rhonchi. In the lungs, the X-ray will show patchy infiltrates that look uneven. ABGs will show metabolic acidosis. Some other factors associated are ethnicity, use of forceps or vacuum, difficult labor, mom who has a history of substance abuse, especially with tobacco and cocaine, infections like chorioamnionitis and maternal hypertension or diabetes, lack of amniotic fluid, fetal growth restriction, prolapsed cord. So we're suctioning at birth. We want to make sure that we're minimizing the amount of oxygen and energy available. We're looking for any meconium stained fluid before the baby takes the first breath. We want to make sure that the nasal cavity and the posterior pharynx are wiped so that the baby doesn't aspirate that stuff. Repeated suctioning and stimulation are limited to prevent overstimulation and further depression. This baby is likely going to go to NICU. We need to make sure the baby has adequate perfusion. We're going to have to hyperoxygenate the baby. All right, monitor those oxygen levels. We might need positive pressure ventilation. The neonatal resuscitation team doesn't recommend endotracheal suctioning for infants born through meconium stained fluid. All right, at birth, the infant would be given to the team for evaluation, and we would use orogastric suctioning to prevent the meconium aspiration. All right, so we're going to hyperoxygenate the baby to dilate the vessels and close the ductus arteriosus. We might even give nitric oxide to decrease the pulmonary resistance. Ventilation to increase the chance of air trapping, and vasopressors and pulmonary vasodilators. Surfactant, because that's going to be decreased. And then we're clustering care. We need that thermal environment to minimize the use of oxygen and parental support. Persistent pulmonary hypertension of the newborn. With this, the baby will have pulmonary hypertension, and we'll see a shunting of their blood and hypoxemia. So the blood will be shunted from right to left. It happens when the baby's circulation system doesn't have that normal transition after birth. And it's because the pulmonary vessels do not relax the way they're supposed to. Persistent pulmonary hypertension is a dangerous condition, and it can cause the baby to have a lack of oxygen after birth. The lungs do not open up fully, and that causes blood to skip the lungs. Remember, at birth, we should have an increase in the blood flow to the lungs, but in these babies, it's not happening. So the brain and the body are not getting enough oxygen. There's too much pressure within the blood vessels, and that is what we call pulmonary hypertension in these blood vessels that are going to the lungs. The high pressure can cause damage to the baby's heart and the lungs. So sometimes we don't know why it occurs, and other times it's due to a complication of perinatal asphyxia, meconium aspiration, from mom having a history of smoking, from maternal obesity, not enough calcium, and there's a few other things that can cause it. We'll see hypoxemia and acidosis, which causes vasoconstriction of those pulmonary arteries and an increase in the pulmonary vascular resistance. Normally with the newborn, we see a decrease there, right? Because the body is changing its route. Before we had fluid in the lungs, now that fluid is going to be removed from the lungs and air is going to be in the lungs. That blood flow to the lungs should be, that resistance to the lungs should be decreased, because we're going to see that increase in pulmonary blood flow to the lungs. But in this baby's case, we're not getting that increase to the lungs because we have an increase in the resistance in that blood flow. So it bypasses the lungs, and what happens is we have this systemic arterial hypoxemia. There is some research that shows that this can be caused by women that take SSRIs in late pregnancy. So we're looking at that. And it's being discussed as to whether or not they should continue that. So we're monitoring the oxygen status. If the baby needs resuscitation, we're going to immediately resuscitate after birth and give the oxygen as ordered. That will correct the acidosis and hypoxia and hopefully prevent the persistent pulmonary hypertension. Most of the time, this respiratory support is going to be seen through the way of mechanical ventilation. Medications are going to be given. So that would be things like sodium bicarb to correct the acidosis, volume replacement to correct the hypovolemia and the hypotension, vasopressors to bring that pressure up. We'll cluster care, we'll monitor that cardiopulmonary status, support, and then when we do any procedure like suctioning, weighing, changing diapers, this can cause hypoxemia in the baby, okay, because they're not stable. So we're going to minimize that stimulation as much as possible. Following statement, true or false, the underlying problem associated with meconium aspiration syndrome in utero involves hypoxic stress.
True.
Okay, true. Meconium is passed in utero, secondary to hypoxic stress, or it can be passed right after birth when the baby takes that first breath if we haven't suction or clean. Intrauterine distress can cause passage of meconium into the amniotic fluid before birth. So we look at that amniotic fluid for what?
For blood, for
that green
The
color,
color?
that green
The
tint,
color.
right? For that green tint that indicates that the meconium is in it. All right, periventricular, intraventricular hemorrhage. This is bleeding inside or around those ventricles, and that's the space in the brain that has the spinal fluid. Remember that there's only a little bit of space up there. So extra fluid, there's no room for it. Because the baby's brain is vulnerable because of the immaturity, especially in that preterm infant, the most vulnerable area is that periventricular area. The area is the rim of the brain tissue that lines the outside of the lateral ventricles. And these ventricles have capillaries that are very fragile and can easily rupture. Any physiological stress or trauma during birth can cause the vessels to rupture and bleed into the periventricular area. If the bleeding continues, it will expand the volume, and it will cause that volume to go into the lateral ventricles, causing an intraventricular hemorrhage. The hemorrhage is most common in preemies, especially low birth weight babies, those under 1,500 grams. Bleeding in that brain can put pressure on the nerve cells and damage them, and that can lead to brain damage or brain injuries. The periventricular areas are important for two reasons. These help develop new brain cells. All right, and those brain cells will eventually end up in the cerebral cortex. And that cortex is responsible for really executive learning, intelligence, learning speech, behavior, personality. It also has influence over our ability to control our muscle strength and control. The motor nerve pathways that carry the signal from the cerebral cortex to the muscles have to go through that periventricular area. This can interrupt the signals to the muscles, and the muscles can become tight, spastic, or hypertonic, or loose, hypotonic, and the client will lose control over the muscle. The baby can experience involuntary, non-purposeful motor movements called athetoid, choreoform, or choreoathetoid. The loss of that normal strength and voluntary control is called cerebral palsy. And that depends on the number and the location of the motor nerve pathways affected. Complications from PIVH include hydrocephalus, because we're having that extra fluid in there, right? Seizure disorder, periventricular leukomalacia. This is an ischemic injury where the white matter doesn't get perfused and it's damaged. Cerebral palsy, learning disabilities, vision, hearing disabilities, cognitive impairments, or death. So we look at the baby, we look at the labs, and things that we look for: unexplained drops in the hematocrit, pallor, apnea, poor perfusion, evidenced by respiratory distress, oxygen descent. We'll look for things like seizures, lethargy, changes in the level of consciousness, bulging fontanelles from that hydrocephalus or increased pressure, weak sucking, metabolic acidosis, and any sort of high-pitched cry or low or hypotonia. Check the anterior fontanelle for tenseness. Check the vital signs, looking for things like bradycardia and hypotension. Why bradycardia and hypotension here? Okay, and then sorry, people always interrupting me with a text message. That gets my brain out of context. Bradycardia, hypotension, and you're looking for changes in the pressure, the pulse pressure, okay? Because these are all classic signs of increased cranial pressure. Something called Cushing's triad, look it up, okay? And you'll see what the signs of increased cranial pressure are. And in the infant, you'll also see something called sunset eyes. If this bleed continues, the baby will be at risk, okay? They'll develop metabolic acidosis, glucose instability, shock, death. So we look at different grades of the bleed. We have like a grade 1 that occurs in a small area, a grade 2, which occurs inside the ventricles, a grade 3 where the ventricles are enlarged by the blood, a grade 4 where we have bleeding into the tissue around the ventricles. Grade 1 and 2 are the most common, and then grade 3 and 4 are the most serious, and they can result in long-term damage to the brain. All right, so we can give steroids to help prevent this. Some interventions we can do are things like delayed cord clamping, limit the amount, how we handle the baby, limit hypoxia. We can correct the anemia, the acidosis, and the hypotension through oxygenation. We don't want to give any rapid boluses or high oxygen or ventilation because they can increase the risk for the baby developing cranial hemorrhages. We keep the baby in a flex position, supine, head along the midline, all right, and avoid lifting the lower extremities with diaper changes. Minimize handling of the baby, clustering care, limit stimulation to reduce stress, reduce exposure to the stimuli, and the baby will need parental support for long-term needs, okay? So we're gonna have to give support to the parents as well. Help them find the proper resources, okay? Necrotizing enterocolitis. This is where the baby doesn't have a proper immune defense built and their mucosal barrier in the stomach is compromised, or the intestines. So the intestine is susceptible to bacteria and opportunistic pathogens. So once we feed the baby, these bacteria can enter the intestine and they'll get this inflammatory response. Now, one of the things we can reduce the risk for this is with breastfeeding. Three mechanisms that will occur here: bowel ischemia. They'll develop this bacteria flora, and a lot of it comes from the feeding. So any region of the bowel can be affected. As the baby gets worse, they'll start to show signs and symptoms of septic shock, respiratory distress, temperature instability, lethargy, hypotension, oliguria. Give me 1 second, guys. All right, so as the necrotizing enterocolitis gets worse, the baby's going to show these signs of shocks. They may have things like abdominal distension, tenderness, bloody stools, vomiting, sepsis, shock. We'll do a KUB to look at the kidneys, the ureters, and the bladder. And what we'll see is air in the bowel wall, known as pneumatosis, and dilated loops of the bowel. Okay, so this is these babies don't have a good day to look at going forward. They're likely not going to survive this. This occurs between 3 and 12 days of life. The blood values can demonstrate metabolic acidosis, increased white blood cells, thrombocytopenia, and DIC, which, you know, they're going to bleed out with that. So if they can catch it quick enough, reverse it, possibly do some sort of surgery, they might be able to help the child. We're going to offer emotional support, listen to the family's fears, teach them when the baby is treated, if we can limit the treatment to a short period of time, we can resolve it within 48 hours of stopping the oral feedings or surgical treatment. All right, it's just going to really depend on how much of the bowel has faced the necrosis, how much is going to need resection, and then they may end up with something called short bowel syndrome or dumping syndrome if we have to take a large portion of the bowel out. So some of the factors that put the baby at risk for this: some prenatal factors like prolonged rupture of the membranes, preeclampsia, sepsis of the mom, infection of the amniotic fluid, and then some other things: respiratory distress syndrome, hypothermia, having a patent ductus arteriosus, because that's supposed to close so the blood goes into the proper circulation after birth, goes into the lungs, and doesn't bypass them anymore. So we're going to want to educate the family. We'll look at risk factors for this. Again, the most effective strategy here is breastfed. All right. When we use human milk, the baby's going to be more at risk for this. We'll also look to see what the residual volume is if the client is getting a tube feeding, okay? Because we have to be suspicious if it's high, if the body's not processing it right. This is going to put holes or strictures in the intestines. So they're going to need bowel rest and antibiotic therapy. So these babies will probably end up on TPN. That's the way we rest the bowels. If we don't give the feeding in the gut, then it can rest. So we put them on TPN. The problem with TPN is high risk for infection, pneumonias, okay, because TPN is high in sugar. So it's a little bit more nursing interventions and things that go into handling that. You have to watch for things like fluid volume overload because it's given in the veins. You have to watch for infections. You have to watch the blood sugar levels because it's high in sugar. You have to follow a strict technique when you're giving it, as far as hand washing and all that. And then you also have to watch for peritonitis, which you would notice with redness or shininess in that abdominal area. So we're educating the family, listen to their fears, teach them about when this would be resolved, what we would expect, that there may be some surgery required. Which of the following would you expect to see in a newborn with necrotizing enterocolitis?
See?
Abdominal distension, all right, tenderness, bloody stools, bilious vomiting. That means you're going to have biliary fluid coming up. Feeding intolerance, lethargy, sepsis, shock. All right, diabetic babies. We're watching these babies that are born to these diabetic mothers or mothers of gestational diabetes because they can have a lot of complications, especially hypoglycemic. If mom has problems controlling her blood sugar, especially in the first trimester, it can cause congenital malformations, especially with the organs of the baby. That could affect their cardiovascular, skeletal, central nervous system, GI, or gerontology system. Cardiac anomalies are the most common. These babies can also be large for gestational age or small, and that depends on how the vessels are affected in mom's body before and during the pregnancy. Mom can produce too much insulin. If the insulin response from her pancreas is either inadequate or too much, then it's going to affect the baby, okay? So if mom's not producing enough insulin, then hyperglycemia in the baby results. And that would manifest as recurrent postprandial hyperglycemia. Those would cause an accelerated growth, and that's why with these babies, you'll see them growing big because they have this excess insulin and excess nutrient storage. Babies are also at risk for physiologic, metabolic, and congenital issues like premature birth, macrosomia, asphyxia, respiratory distress, hypoglycemia, low calcium levels, jaundice and hyperbilirubinemia, polycythemia, hypertrophic cardiomyopathy, and other congenital anomalies affecting the central nervous system especially. So we want to keep the type 2 and type 1 diabetes in control. Babies born to type 1 diabetics could also develop those neurotube defects, cardiac defects. So we definitely want to make sure that mom is controlling. If mom has unstable type 1 diabetes, baby can also develop intrauterine growth restriction, asphyxia, and fetal death. Usually with type 2, the babies tend to have things more like excessive weight or macrosomia and other mild conditions. And then the energy associated with converting the excess glucose into fat causes depletion in the oxygen levels for the baby. So we'll see fetal hypoxia. And with that, along with that, we'll see surges in the catecholamines being released by those adrenal glands. And that causes things like hypertension, cardiac remodeling and hypertrophy, stimulation of erythropoietin and red blood cells, leading to increases in hematocrit, polycythemia, and again, that's going to cause problems with circulation and jaundice because of the excessive bilirubin. The babies also will have an increase in the weight of their organs. So some of their organs might be a little large compared to other babies. They might also have things like excessive fat in the shoulder and the trunk, and that can put them at a higher risk for things like shoulder dystocia, brachial plexus injuries. The small gestational age infants will usually suffer from things like malnutrition, low glucose reserves. The circulation of the placenta is often impaired, and that can lead to poor growth. It also can cause blockages in the arteries to their kidneys. So at birth, we're looking at the baby for certain characteristics. Puffy cheeks with a ruddy skin color, a short neck or no neck appearance, a buffalo hump over the nape of the neck, massive shoulders with the full intracapular area, distended upper abdomen due to organ overgrowth. Remember, I said we're going to have those large organs. Excessive subcu fat tissue producing fat extremities. So we want to prevent hypoglycemia by introducing feedings early. Keep the blood glucose above 40. And watch for signs of hypoglycemia, which would be listlessness, hypotonia, apathy, poor feeding, decreases in the oxygen levels, cyanosis, instability in the temperature, and then pallor, sweating, tremors, irritability, seizures. So early feeding within 1 hour of birth and every 2 to 3 hours. Avoid cold, stress. That increases the demand for glucose, and they need rest periods. Watch for signs of trauma, especially trauma to the head. So we're looking for tense, bulging fontanelles, cephalahematomas, skull fractures, nerve paralysis to the face, shoulders and extremities, any sort of bruising. Any sort of cyanosis, pallor, modeling, and you're looking at that cap refill to make sure it's brisk and not sluggish. Check that body temperature frequently because keeping the baby warm prevents that cold stress and that hypoglycemic state. Hypocalcemia, we might see this in the first 2 to 3 days of life, and that could be caused by a birth injury or by a delay in the parathyroid production. Sometimes we'll see hypomagnesium along with the calcium levels. So if the calcium goes low, the magnesium is likely to go low also. So you want to look at this, especially if you give something for the hypocalcemia and we don't see a change. Red blood cells can break down. That leads to an increased hematocrit and polycythemia, and also the risk for jaundice because of the excessive bilirubin. Help the parents and the family understand what's going on with the baby, provide support, teach them about breastfeeding. They may think because the baby's big, the baby's healthy. All right, but that's not true. Look at substance abuse, because these can also cause problems with the baby. So anyone who's at risk for using any alcohol or illicit drugs or tobacco, these will all put the baby at risk. They don't know the full extent, all right, but it can result in premature birth, miscarriage, low birth weight, behavioral and cognitive problems. When a baby is born addicted, they can be addicted to things like tobacco, alcohol, marijuana, opioids, morphine, methadone, CNS stimulants. So the baby can be born with anything that the mom is constantly using that crosses that barrier. And how bad it will damage the baby depends on how often, how much, and what point of the pregnancy she used it in. Fetal alcohol syndrome and spectrum disorders are documented and attest to developmental delays, intellectual delays, attention disorders, and psychopathologies. Prenatal alcohol exposure induces a variety of adverse effects on these babies. Findings with fetal alcohol syndrome include growth restriction, craniofacial structural abnormalities. You really see that with the eyes and the nose. Distinctive findings characterized by the physical and mental disorders that appear at birth and remain problematic throughout the child's life. So in order to diagnose someone with fetal alcohol syndrome, they would have to have the 3 facial abnormalities, the growth deficit in the weight, height, or both, less than 10 percentile, and documentation of the central nervous system abnormalities like structural, neurological, or functional issues. So you can see the different things that on the slide that can cause this. Pretty much anything you put in your body that's considered harmful. Look at mom's previous history, risky behaviors, and we may even do a toxicology report depending on your state. It's not uncommon to walk into one of these rooms and find mom with the cannabis, with the cocaine, the crack, the alcohol right at the bedside. And then we have to do a withdrawal assessment on the baby to see if the baby's addicted. All right, we're gonna have to, for the baby, provide comfort, reduce the stimuli, make sure the baby gets enough nutrition, because in some cases the metabolism is gonna be increased. Then we're looking at ways to prevent complications. Okay, so withdrawal for these babies will begin within 48 to 72 hours after birth. A lot of times the baby's already home at this time if we haven't done the neonatal abstinence screening on them. They may have things like CNS hypersensitivity, autonomic dysfunction, respiratory distress, inability to control the temperature, hypoglycemia, seizures, tremors, hyperactiveness, abnormal crying patterns, feeding difficulties, yawning, stuffy nose, sneezing, GI disturbances. This is a major challenge caring for these babies. The first line of treatment would be non-pharmacological. So comfort by relieving the symptoms, improve the feeding and the weight gain, prevent the seizures, and promote mom and baby interaction. Supportive interventions include swaddling, low light, gentle handling, quiet environment with minimal stimulation, soft voices, pacifiers, promoting self-soothing behaviors, frequent small feedings, kangarooing, and rooming in and positioning. Other techniques like gentle rocking using a flex position and a pacifier help with the CNS irritability and a calm, gentle approach. Newborns suffering from this will have an impaired feeding behavior. So they may engage in things like excessive sucking, poor feeding, regurgitation, and diarrhea, and this can cause weight loss. We'll supplement them with high-calorie formulas, frequent small amounts, upright positioning, so they may need up to 150 to 250 kcals per kilogram per day for proper growth. All right, because remember, they're going through withdrawal, so their body is going to be engaging a little different than a regular newborn. And also breastfeeding unless mom is still using the drugs. She's still using, then we don't want her breastfeeding because a lot of those drugs will cross that barrier. We have to monitor their weight, check their hydration status and those fontanelles and the bowel movements. Also, we're monitoring their fluid and electrolytes and their acid-base status. If those things don't work, then we'll go to pharmacological treatment. All right, so first thing is decrease the stimuli and do things like swaddling. If we are going to give something to the baby for withdrawal, it might be morphine or methadone, buprenorphine or barbiturate, phenobarbiturals, or clonidine. They're also at risk for skin breakdown. And we have to teach mom how to take care of the baby and what to do. Again, we're going to have to evaluate mom too to see if she's even going to be safe to take care of the baby here. All right, so make sure you know the signs. They will test you on this. I would be aware of it. That necrotizing enterocolitis, I would be aware of that. Meconium aspiration syndrome, tachypnea, transient tachypnea. These are all things they test on. All right, here's your acronym for the withdrawal. Again, I'm going to send you guys these slides. L to R, if you're coming on for L to R, just be patient. I'll be with you guys shortly. All right, at birth, okay, we want to support. So we're looking for any injuries to the baby. This can be for any baby, not, now we're past the neonatal syndrome. So now we're just looking at birth trauma. All right, 3 most common birth traumas are injuries to the scalp, injuries to the skeleton, and fracture of the clavicle. Most of the time that has to do with positioning, the size of the baby, or the size of the birth canal. So we have compression to the head, contractions, traction, the presentation of the baby, the size of the baby, or the neurologic immunity can complicate that process. So remember, we talked about those 5 Ps, like the force of labor. All right. Other things that could affect this would be edema, hemorrhages, or fractures. We might see trauma in the baby from any sort of abrupt labor, abnormal, or difficult presentation. Any sort of mechanical forces used, like forceps or vacuum. So we got to be supportive. We're looking for resolutions. Provide the parents explanation and reassurance that the injuries can resolve with minimal or no treatment. Remember, they may be alarmed if their baby's not able to move, or if they don't show proper facial movements they would expect to see. Parents are going to need time to understand. And then they're probably going to need some sort of referral. All right, too much bilirubin. So again, physiological jaundice around the 3rd or 4th day of life. We can prevent this with early onset breastfeeding. If we do late breastfeeding, jaundice typically would occur between the 4th and 7th day of life, when that mature milk begins to replace the colostrum. So right after the baby's born, frequent effective breastfeeding will reduce the risk of this. Number one cause of this physiological is the breakdown of those red blood cells. All right, so you have to know the difference between physiological and pathological. This is what they're going to test you on mostly. Pathological is going to occur within the first 24 hours of life. Physical does not. Intervention is required with pathological jaundice to prevent that bilirubin encephalopathy. Remember, that can do brain damage. All right, that's when we get that unconjugated bilirubin in the basal ganglia or the brainstem. Most common condition associated with pathological is hemolytic disease of the newborn due to incompatibility of the blood group of the mom and the baby. So that Rh factor, that ABO incompatibility. All right, so you're looking at the record for risk factors. You're evaluating the baby for jaundice. Remember, you do that every time you do the vital signs. You're looking for any signs of Rh incompatibility. Check those bilirubin levels. So Rh incompatibility would be ascites, anemia, congestive heart failure, edema. That can happen anytime mom and the baby's blood mixes. And that's why we give that RhoGAM anytime there's a chance for it to be mixed, or we would do the Coombs test to roll what out what we need to, okay? So physiological jaundice may result from increased bilirubin because of that polycythemia, the immature liver. We have 3 reasons for physiological increased bilirubin production. Inability of the body to remove it due to liver immaturity. Sometimes we can delay the cord clamping, and that can help with some of this. Pathological jaundice. Remember, is going to be most likely related to that Rh incompatibility. All right, so early breastfeeding. If you're going to use the lights should be about 12 to 30 inches above the baby. Cover the baby's eyes with patches and cotton balls. Keep the baby undressed except for the diaper area. Cover the eyes. No. Yep. Turn the baby every 2 hours so that all the body's exposed. Only take them out of the lights for feeding. Remove the eye patches during feeding so you can interact. I'm sorry. 4.5 hours you guys had. Yep, you can go. Make sure the baby's temperature, weight, and fluid intake are monitored daily. Document the frequency, the color, and the consistency of all stools. Those stools are going to be loose and green. because they're removing that bilirubin. Remember, that's how it's excreted from the body. So we got to make sure the baby's pooping. Skin clean and dry, and feeding. And we may even give the baby glucose water if it's allowed to provide added fluid, protein, and calories. All right, so with sepsis, this is that bacteremia. So we have that infection in the blood. It can happen in the first month of life because babies are more susceptible that time. They have an immature immune system. They haven't developed all those antibodies. They have limited antibodies that are received from mom during pregnancy and then at birth. Remember, the main ones that they'll get is IgG, which is limited, and IgA, which comes mostly from the breast milk. So if they're not doing breastfeeding, some of those babies won't get as much. All right, so you should know the differences between these different infections. All right, congenital, this is usually caused by some sort of intrauterine infection. Early onset, which happens during the perinatal period, and then we have late onset. So you're going to look at the risk factors. Some things that you might see here are elevated C-reactive protein and positive blood cultures. Early neonatal infections, those less than 72 hours, are usually from mom's gerontary system. A lot of times from a group B infection, E. coli, or staph. Late onset usually happens in the postpartum period, and it's usually considered horizontal transmission. It comes from healthcare workers or from family members or caregivers, usually on the hands. All right, sometimes through breastfeeding as well. So you're going to look at the blood counts for anemia, leukocytosis, leukopenia, elevated C-reactive proteins. You'll get x-rays of the chest and the abdomen. And then we're looking for different cultures that would confirm the infection. With the baby, you'll see non-specific things like they can't control their temperature, blood pressure's low, tachycardia, pallor, poor tone, cyanosis, poor weight gain, poor feeding, respiratory distress. We'll manage this with antibiotic therapy that goes after the targeted pathogen. So once we do the culture, we'll use that culture to determine what antibiotic. The antibiotic can be about 7 to 21 days or discontinued within 72 hours if the cultures are found to be negative. And then along with antibiotic supportive care. All right, so some of these antibiotics, ampicillin plus gentamicin or cefotaxime. Now, what did I say about the gentamicin? What I say about those mycins?
The hearing?
Right, mycins never let you win, right? Toxic to your kidneys and your hearing. If you damage this baby's hearing, you're not getting it back. So remember that, okay? It's not coming back if you damage it. All right, congenital conditions, any birth defect at birth. If the infant's born with it, it can be traumatic. So we're gonna have to do support for these families. Neurotube defects are of the brain, the spine, and the spinal cord. And it happens in the first month of pregnancy when the woman doesn't usually know she's pregnant. These are things like spina bifida, encephalopathy. All right, in spina bifida, the fetal column doesn't close completely. We have nerve damage and paralysis. In encephalopathy, the brain and the skulls don't develop. The babies are stillborn or die shortly after birth. And another defect is Chiari formation, which causes the brain tissue to extend into the spinal cord. LR, we got about 5 more slides and then we're going to start. All right, esophageal atresia, we talked about this. All right, this is your neurotube defects we just talked about. I would know, look up and know what these are. Onthocele and gastroschisis. In gastroschisis, the organs are born outside, and so they put this sterile bag over the baby's gut. Know what it looks like, know what it is. They like to test on it. Imperforate anus. Okay, so in here, they can't use that anus, right? They're gonna have to have some sort of surgery. And bladder extrosophy. So look those up. And then the esophageal atresia, which we talked about a little bit ago. This is where it's dangerous because the foods and the saliva travel through a hole in the baby's trachea and go into the lungs. So chronic signs of these are the 3 C's: coughing, choking, and there's another one, cyanosis. Okay, baby will have this blue color to them. So it's a type of pneumonia, aspiration pneumonia. The baby doesn't have that connection there. So the food is going to go into the lungs as opposed to the esophagus and the stomach because it's not connected. First sign, the fetus cannot swallow and absorb the amniotic fluid in utero. So after birth, the baby will have this copious, frothy bubble of mucus in the mouth and the nose, accompanied by drooling. The esophageal atresia and fistula. All right, so these babies will have this fistula, and it increases the risk for pneumonitis and atelectasis due to aspiration of the foods. Again, the 3 C's: coughing, choking, cyanosis, diagnosis by X-ray, ultrasound, or MRI. Pre-op, nothing by mouth. Elevate the head of the bed 30 to 45 degrees to prevent aspiration and reflux. You're monitoring hydration, fluid, and electrolytes. Oxygen and suction equipment available. Comfort measures for the baby to minimize crying and respiratory distress. And then non-nutritive sucking for this baby. They're going to need surgery, okay, to join the 2 segments back together. So that's what's going to help them. The omphalocele, this is an umbilical ring defect with evisceration of the abdominal contents into the peritoneal sac outside. Gastroschisis, there's the picture over there on the slide, or you see it on the next slide, okay, where we have this abdominal content that goes right through the wall. They have no peritoneal sac. So you have to protect these babies. You have to protect rupture. You have to maintain fluid and electrolytes, maintain that thermoregulation. This is the omphalocele. Your gastroschisis, look at all those organs out there. Again, this is the one where they use that plastic bag. You see the plastic bag on the next slide. I would know it. They like to test on it. And then the imperforate anus, okay, the rectum ends in a blind pouch or fistula. So there's no anal opening. The baby can't pass any stool. Surgical intervention is going to be needed for these babies, okay? The bladder, extrophy, this is the protrusion of the bladder into the abdominal wall. We have separation of the rectus muscles and the symphysis pubis. The bladder doesn't form and it's flattened and exposed and the bones are widely separated. All right, so again, complications would be things like UTI. It's going to need surgery. That's it, guys. All right, I can't finish the other chapter, but what I will do is I do have chapter 23